Let's simplify TB, its pathophysiology, diagnosis, and treatment in a quick, easy animation watch till the end. So, first, the inhalation of the aerosol droplets occur. Then, TB can have four outcomes. First, the clearance of the organism. So, the organism reaches the alveoli and are eaten by the macrophages, and the infection clears. So, here you can see the organism coming in and the infection getting cleared by the macrophage. Then, the primary disease. If the bacillus survives and starts causing the infection, it causes the primary TB. Now, the latent TB. If the immune system traps the bacillus inside a granuloma and it becomes inactive, this is latent TB. Now, the reactivation of the disease. When immunity weakens due to HIV, malnutrition, diabetes, age, or steroid use, the granuloma begins to break apart. Dormant TB wakes up, multiplies, and causes reactivation of the TB. Now let's discuss the diagnosis of pediatric TB. When a child presents with persistent fever, weight loss, or chronic cough that doesn't improve, TB should always be considered. The next step is tuberculin skin test or an interferon gamma release assay. A positive test means exposure, but it does not confirm the active disease. On a chest X-ray, pediatric TB most commonly shows hilar lymphadenopathy. You may also see a miliary pattern, those tiny millet seed-like nodules scattered throughout the lungs. Evaluate for meningitis if symptoms suggest it. If the child has vomiting, irritability, seizures, bulging fontanelle, or altered mental status, think tuberculous meningitis and always perform a lumbar puncture immediately. Early diagnosis here saves lives. And always assess for HIV and malnutrition because both sharply increase the risk of severe and disseminated TB. Once you have confirmed the TB, now the next challenge is to treat it correctly, especially since children require careful dosing, monitoring, and follow up. Let's break the treatment into simple 6-month roadmap. For most pediatric TB, the entire course is 6 months. The intensive phase is in the first 2 months using RIPE regime, rifampicin, isoniazid, parazinamide, and ethambutol. And then we enter the continuation phase, 4 months of the isoniazid and rifampin. For tuberculous meningitis, treatment is extended to 10 to 12 months. This is crucial because the TB in the brain behaves differently and needs prolonged therapy. We always supplement with pyridoxine or vitamin B6 to prevent isoniazid-induced neuropathy. This is especially important in malnourished children. And you must monitor the LFTs regularly. Ethambutol can cause optic neuritis, which affects color vision, so watch closely for visual symptoms. And finally, adherence is everything. That's why many programs use DOT therapy to ensure every dose is taken and to prevent drug resistance. Teaching is done by Dr. Yumna and animations courtesies by Dr. Ahmed Unal, MD. If this animation helped simplify TB for you, please don't forget to subscribe for more pediatric explanations and high-yield clinical videos like this. Thank you so much.